गुड इवनिंग. चालू करे क्या? हाय सर.
Hi, good evening. So nice to see you.
पिछली बार भी ज्वाइन होने वाला था लेकिन थोड़ा बिजी था सर. लेट
हाँ,
हो
नो
गया.
प्रॉब्लम. नहीं, क्या हुआ, मैं तो सोचा कि पहले थोड़ा कमरा लोग का नॉन मैलिग्नेंसी का टॉपिक कवर कर लेते हैं, then now we will continuously will be doing all malignancies only.
Right, sir.
So आप भी थोड़ा कुछ रेडियोलॉजी में सीटी, ईमेल, वो सब जरा हमको बता देना. हाँ,
Okay.
you guide all the students also. Okay.
ठीक है सर.
We'll just wait for 5 minutes, Dr. Gite and all they join, then we'll start. And let my student start the case presentation.
Gite joined already.
How Gite is joined?
Yeah.
Dr. Gite is already joined.
Sir, good evening, sir.
Good evening.
क्या चल रहा है? कल आज सुबह एकदम बारिश के सीजन जैसा बारिश हुआ मुंबई में.
बहुत बारिश था. Sudden change in weather.
सर मुझे लगता है होगा ही. इतना वॉर्स वगैरह चल रहे, इतना हीट पैदा होता रहेगा, कितने करंट्स पैदा होते रहेंगे. एंड वी टॉक अबाउट हम लोग डीजल वापरते कि गैस वापरते.
मॉर्निंग में निकलते हैं तो ऐसा लगता है जैसे धुम्मस है.
नहीं, बट whatever said and done, these wars वगैरह where इतने सारे bombs, missiles वगैरह फूट रहे हैं, they must be affecting the whole earth badly.
Correct.
Correct, sir.
हम लोग सीधा इग्नोर करते हैं. मतलब ये keep on blaming developing countries.
Sir, who will be answering today, sir?
क्या बोले? I didn't get that.
Sir, who will be answering today?
Sir, I'll be answering.
Today, who is answering?
I'll be answering, sir. Dr. Tanmay.
Dr.
Tanmay.
Anmay, na? And
Tanmay.
Who else is there?
Good evening, sir. I'm Dr. Sai. I'm also answering.
Dr. Shahid and Dr. Tanmay, na?
Yes, sir.
Sai.
Good.
Yes, sir.
Good evening, Dr. Miraj. I am also answering.
Okay.
Great. I hope if you three answer, then I don't have to answer.
We are happy that Miraj is volunteering and, that will, the other female urologists who are presidents, they also will come forward to answer. Miraj, who else is there? Who other female urologists? I mean, the residents are there?
Sir, काफी रहेंगे ऐसे क्या?
No, in this group, whether she knows anyone.
Dr. Gitanjali is there, Dr. Satyasri is there, Dr. Homera is there, and yes, so these are the people I know.
Okay, so you can tell them also to answer.
Okay, sir.
I'm sure you must have benefited. Means, you are gaining after answering for last 2 times. You must have gained quite a lot of confidence. What do you say?
Yes, I read this topic in the last 2-3 days. For all the only 2-3 days, I have read all these topics.
No, that's okay. But when you start, even in the board round or if you're going there, I'm sure you must be feeling more confident in talking and answering.
Yes, sir.
Yes, not join.
Ganesh sir.
Yeah.
25th को वेस्ट जोन का जूम मीटिंग है आपका मैलिग्नेंसी का होने के बाद में.
मैं ज्वाइन करता हूँ सर, वो मुझे जरा बाहर जाना है एक्चुअली.
नहीं नहीं नहीं, जस्ट शायद उधर है KDH में, फिर बाद में फिर शायद इधर का है 7 to 8:30 का, तो पॉसिबल है तो ज्वाइन करने में हर्ज नहीं. Some different new people are presenting, and all the new people are chairing the sessions only.
चलेगा सर.
So we request all the students also to join, because there is a residence corner as well as the consultants corner. So you can see that how different people they present and what are the different case scenarios. So in future you can also join us, because this will be like continuing every 2 months, 3 monthly. That is what our plan is. So we request all of you to spare some time on 25th, that is Saturday, 7 to 8:30. I'm just waiting our resident Swastik to join, and he will start sharing screen.
I think यूरोलॉजी सोसाइटी ऑफ इंडिया का जो सबसेक्शन हो गया है.
Yeah.
It is like sometime I feel it is now, increase the
Conferences, webinars.
हाँ, मतलब it is like too many conferences happening. How can you devote so much time everywhere?
Every alternate day there will be a message from somebody, book your dates. Good evening, Pankaj sir.
Good evening, sir. It's very
I was
difficult.
thinking मैं इस मामले में चुप ही रहूं तो अच्छा है.
नहीं मतलब, sir, you can say something. It's like too many meetings and I don't know who is. Nobody's bothered.
ना अभी इतना है कि जो आपने को अच्छा लगता है उसमें जाना, नहीं अच्छा लगता या ना इंटरेस्ट का उसमें चुपचाप रहना, ऐसा ही सॉल्यूशन है, दूसरा कुछ नहीं कर सकते.
Finally यही होगा डॉक्टर साहब. Obviously nobody can attend every meeting.
Yes.
I liked somebody, I don't remember who was saying this in Pune, that we can sustain full 1 year just going from one conference to other.
That way we are lucky. Many people doesn't want us, so we don't have to go. Probably
Nice.
they don't need us.
छोड़ दो सर, चलता है.
That's okay.
Yes, a part of game है.
Yeah. We are getting enough time to teach here.
What are we waiting? Where are we waiting?
I'm waiting for that resident. That resident has to join. He told me that he is just joining in 2 minutes. He was little busy in ward. We are 26 urologists. So I may finish earlier on Tuesday, but some other surgeries are going on, so they are little busy.
Good.
And one of the resident has gone on marriage leave. So we are down only with 2 residents. But he is just on his way. He's told me just 2 minutes. That urethroplasty workshop was very good.
Okay.
True, sir. All complicated cases made simplified by world-class urologist, reconstructive urologist.
That's true.
What I loved was the time spent in skin closure. means in the hypospadia surgery, the amount of time he took to do the reconstruction, he probably spent the same time or more in skin closure. Means that really shows how much importance they give to cosmesis in the end.
No, sir. That is the only part which the parents can see.
True, true.
So if you not spend time in that particular stage, and if there is a small blackening, superficial, deep, some gangrene, some stretching, wound gap, then that will show very ugly results in spite of having a good tube inside.
Absolutely. No, that was my biggest takeaway in that meeting, and he planned things so meticulously. The way he made the skin closure, it was wonderful.
True, sir.
Yeah. Even subacute stitches he was taking normally. So we have, that these are the small things which we have learned. Achin,
Yes, sir.
Started. He joined, sir.
Achin, you will be presenting?
Yes, sir. I'll be presenting.
Okay, you're presenting, na? Okay, then start sharing.
Yes. Can you see my screen, sir?
Yeah, now we can see.
Sir, scenario 1.
Okay, Achin, start.
Yes, sir. A 77-year-old gentleman from Dubai presented with complaints of difficulty in passing urine since 3 months.
Fine. Okay, so this is a history, how we are going to ask your questions.
Sir, I want to elaborate the presenting complaint, sir. He came with complaints of difficulty in passing urine. So I want to further elaborate this in the form of taking the history in the form of storage loops and voiding loops, sir. So storage loops which include frequency, urgency, and nocturia, and voiding loops which includes poor stream, straining, incomplete emptying, and intermittency. And whether this patient is having whether this patient is having any associated pyuria, hematuria, fever, vomitings, whether any pedal edema is there or dyspnea is there, and whether any history of lithuria is there, and whether any complaints of loss of appetite and loss of weight is there, and any past history of surgeries are there, and any history of cough, hemoptysis, or dyspnea or jaundice is there.
Anything else, Mehraj, you want to add? So what are the possibilities at the age of 78? What are the differential diagnosis that comes to your mind?
Sir, first, as a patient came with difficulty in passing urine, 77-year-old, so I want to keep benign prostatic enlargement as my first differential, and then carcinoma prostate as my second differential, and also stricture urethra.
Listen.
Sir,
Depending-
I'd like to add vesicle calculus, neurogenic bladder, and possibly trigonal
Yes.
bladder malignancy as other diagnosis. Differential.
So, at present, you have only a complaint of difficulty in passing the urine. Okay.
Yes, sir.
And the
Yes, sir.
age of the patient is 77 years, and the history duration is only 3 months.
Yes, sir.
So the thing come to in your mind when such patients come to the OPD is it may be a major possibility is enlargement of prostate either benign or malignant.
Yes,
That is
sir.
a first. Second, after elaborating this complaint and asking the positive past and associated history, then only you can judge about the other causes. Because
Yes, sir.
age and difficulty, these are the only two things, and which shows that this patient may have a enlarged, definitely enlarged, symptomatic enlarged prostate, maybe benign or malignant.
Yes, sir.
So whatever other causes you are told, with only these symptoms may not stand true at this juncture.
Okay, sir.
Okay. Achin, go ahead.
Yes, sir. Patient was apparently asymptomatic 3 months back when he started developing difficulty in passing urine, as in poor flow of urine and increased frequency every 1 to 2 hours. No history of hesitancy or intermittency, serious in onset, gradually progressive with no specific aggravating and relieving factor, associated with straining during passing urine and nocturia 2 times per night. IPSS score is 14/35 in this month. Quality of life is bothersome symptoms. Moderate bothersome.
Yeah. Go ahead.
No history of urgency, no history of burning micturition, no history of abdominal pain, fever, no history of vomiting, no history of hematuria, lithuria, no history of facial puffness, exertional breathlessness, lower limb edema, no history of backache, bony pain, weight loss, no history of previous instrumentation or retention.
Fine. So, Mehraj, you want to add anything?
Any history of dysuria and history of infections, recent infections, urinary tract infections, and any history of phimosis, inability to retract the prepuce, and any history of taking any alpha blocker, and any yes, any yes, sir. History of taking any alpha blocker, and family history of any carcinoma, as he is 77 years old.
I request all the residents, whenever such case come in front of you, there should be 2 to 3 negative diagnosis, the diagnosis in your mind. And for asking the negative history, you should club the 3-4 symptoms of each diagnosis and tell in one line, so that the examiner will know you are asking about, for example, malignancy. So there hematuria, low backache, constitutional symptoms के साथ अगर पूछ लिए तो उसे prostate, या फिर हिस्ट्री ऑफ पासिंग द स्टोन, यानी सर्जिकल इंटरवेंशन, एंडोस्कोपिक इंटरवेंशन, उस वो अगर लिथुरिया है तो वो स्टोन के लिए, तो ऐसा तुम ये कंसल्टेट करके लिख के रखो, सो दैट कि इसमें टाइम वेस्ट नहीं होगा और आप जल्दी आगे चले जाएंगे.
Fine. So, Achin, go ahead.
Yes, sir. Known case of diabetes mellitus on oral hypoglycemics since last 5 years. No history of any surgery in past. Family history, no history of any malignancy or malignancy-related deaths in family. Personal history, diet is mixed, appetite adequate, bowel regular, bladder altered as already described before. Sleep is disturbed due to nocturia. Patient is non-alcoholic, non-smoker, and non-tobacco chewer.
Yeah. Fine. This
Yeah,
is a history.
so what
Now,
is the
what you want
impression
to
at
do?
this time? What is your clinical assessment?
Sir, my first differential diagnosis includes benign prostatic enlargement. Second one is CA prostate. Third one is vesical calculus with BPH. And then fourth
Why
one
are you
is
still
neurogenic
going
bladder.
to vesical calculus? What are the features of vesical calculus in your history and clinic up till now?
Sir, patient is having decreased stream and straining, and he's also a diabetes. So I'm thinking in terms of the neurogenic bladder also, or BPH, which might have led to the vesical calculus formation.
Okay. So basically at this time with history, we can just say that we are dealing with bladder outlet obstruction, most likely BPH. And I would keep a differential diagnosis of cancer prostate.
Okay,
to
sir.
call vesical calculus, you should need, say, a history of hematuria, history of sudden stoppage of stream, okay, maybe
Yes.
suprapubic pain, none of them is there.
Okay,
For
sir.
bladder tumor, again, there is no hematuria. For stricture, there is no instrumentation.
Yes, sir.
So just say what we can infer based on the information we have received. Unless
Okay, sir.
examiner keeps on coaxing you, what else, what else?
Okay, sir.
Okay, so why should I think of vesical calculus? I would not think of vesical calculus here.
Agreed.
चलिए आगे बढ़े.
Now, my one question is, he has said about the malignancy. You think in this malignancy related death or anything in there, what is the significance? Any one of you can answer.
Sorry, sir, I didn't get your question.
He has
Sir
mentioned
is
there is
asking what is
no-
the significance of family history of malignancy or death due to malignancy in family.
So there's a high likelihood of malignancy, like a relative risk of 2 with a first degree relative, single first degree relative, and with 2 first degree relatives, a relative risk of 4 when it comes to prostatic malignancies. So malignancies in the immediate family of the patient have significance for the same.
Okay. So can you just tell me the syndrome which can be associated with malignancy CA prostate?
BRCA1 and 2 are associated with CA prostate
I don't think that can be called as a syndrome.
syndrome.
Fine, Achin, go ahead.
Yes. There is a general examination. Patient is conscious, cooperative, very well to time, place, and person, moderately built-in nourished. Pulse is 80 beats per minute. BP is 110/80. Respiratory rate 20. Afebrile. Respiratory 98%. BMI 24. Karnofsky score is 80. No evidence of pylori teres, sinuses, clubbing, lymphadenopathy, edema. Head to toe spine and spine examination is grossly normal.
Okay, how
Good.
now next, Miraj, what you want to see?
General examination is completed. It is so I would like to do the systemic examination of the patient.
Fine, Achin.
The local examination, patient examined supine position with implied informed consent, exposure from nipple to knee, inadequate room light, external genitalia normal, circumcised, penile meatus normal, all hernias or orifices normal, no palpable urethral thickening or mass. For rectal examination shows no fissure, fistula, hemorrhoids, anal tone normal, prostate grade 3 enlargement, hard in consistency, nodular, non-tender, upper border cannot be reached, and median sulcus not palpable. Rectal mucosa mobile, rectum empty, no blood on gloves. And systemic examination is essentially normal, sir.
Ganesh, now I think you should take over from here.
Yes, sir. So this is the per rectal examination. So finally, that's the last thing, right?
Correct.
Clinically, this is the last thing.
Okay, so what is your clinical diagnosis and further?
So my clinical diagnosis will be as a high likelihood of carcinoma, blood outlet obstruction secondary to a CA prostate in a 77-year-old male. And further, I would like to go ahead with the routine blood investigations like CBC ring function
Here
test.
says hard consistency, nodular upper border of
Cannot be
prostate
reached.
not reached. Means what?
There is a gross enlargement of the prostate.
Gross enlargement. Okay.
So which are the conditions where you get a hard prostate?
Granulomatous prostatitis, chronic prostatitis, TB prostate, calcified prostate.
Calcified prostate.
Yes, sir.
Okay, I have not seen up till now.
Okay.
What is your final diagnosis now? You said already, right? So go ahead.
Yes, sir. I'd like to go ahead with the routine investigations and the serum PSA and an ultrasound exam of the abdominal pelvis.
Sir, hemoglobin is 12, count is 8,000, creatinine is 0.6, serum PSA is 13, and urine print micro shows RBC is nil and WBC is occasional. And USG QOB shows bilateral kidney normal in shape and size and location. No evidence of calculi. Prostate volume is it's not 22, it's 62 cc. Sir. 62 cc. Pre-wide 180, post-wide 55.
So Tanmay, you had asked all these things, right?
Yes, sir.
PSA has come 13.27. Is this PSA going to be present with somebody with LUTS? Possible, not
Yes.
possible?
Possible.
Possible, sir.
Okay. Then what will you do next now? You've got enough information.
Yes, sir. I'd like to go ahead with the MP-MRI of prostate, sir.
Why do you want an MP-MRI of prostate when this is a clinically palpable disease?
So firstly, yes, it's a grossly enlarged prostate with multiple nodules, but along with that, we can also get an idea about any presence of any extraprostatic extension of the prostate, any presence of lymph nodes in the pelvis and the local lymph node status, along with the invasion of the neurovascular bundle to again substantiate the treatment.
Fair. So you are basically why not do this after biopsy once you have the biopsy report?
So the biopsy might cause some internal hemorrhage and alteration the radio texture of the gland. That for that we'll have to delay the MP-MRI for a few weeks. So for that, better do a MP-MRI first and then go ahead with the biopsy would be better.
Perfect. So at this time, even though clinically palpable disease, doing the MRI probably is a good idea. It will give you a lot of information which will help you later on in the treatment.
Yes.
So my question is, suppose MP-MRI is not suggestive of malignancy. In this case, you will go ahead with the biopsy or you will not go ahead with the biopsy?
Sir, because it's a
biopsy.
Yeah, because it's a clinically palpable disease with the raised PSA, I will go ahead with the biopsy.
Okay.
Considering the age of the patient 77 years, then MP-MRI may not avoid your biopsy. Second, then MP-MRI may not be good in assessing the nodal status compared to the CT scan or PET scan. Can MP-MRI will be delayed for doing after the biopsy? This is again same question what Pankaj sir has asked. After doing the biopsy, already he is 77 year. So the radical surgery, option of radical surgery probably may not be in your on your table. So what is your stand in such situation? Because here operation तो लगने का chance कम है और लगा भी तो करने का चांस कम है पेशेंट का फिजिकल फिटनेस एंड सो एज कंसीडर करके.
Do you agree with what sir has said? What are your
So I will still prefer to do an MP-MRI. In case the patient is skeptical and everything, I'd like to discuss that option with the patient regarding the possibility of a difficult surgery and that the histopathological diagnosis will give us a final thing. But in case for local staging, either ways, MP-MRI will remain the gold standard. So I personally will go ahead with MP-MRI first. Sir.
Good.
Fine. So Achin, show them.
The prostate is 62 cc. Prostate is normal size, reveals loss of zonal morphology. ill-defined T2 hypointense lesion noted in midline and right peripheral zone predominantly, with partial extension into transition zone. Bilateral seminal vesicles unremarkable. On post-contrast, it reveals early enhancement and subtle restricted diffusion in right peripheral zone. No enlarged lymph node seen. No free fluid seen within pelvis.
Now, can't you see little discrepancy between sonography, clinical examination, and MRI?
Yes, so there's only a single lesion mentioned in the right zone and midline, where it was a generalized hard nodular grossly enlarged prostate on clinical examination.
So what all other information would you like with this MRI if you are the treating clinician?
Sir, I want to know about the pyrite score.
Okay, so pyrite score should be mentioned about the lesion which is hypointense.
Lesions. And what about the size of the lesion?
Size of the lesion, okay. And
Any
extension beyond
extraprostatic
the
extension?
Yeah.
extension where?
The extraprostatic extension, sir.
Okay.
Except they've not mentioned pyrites in this MRI.
Okay. So generally, we also want planes with the surrounding organs.
Okay, sir.
We would also like to know about any kind of median lobe or something is there for this patient. The prostate volume is very small here.
Sir, 62
I think
cc. By mistake, it's 20 cc. 62.
Okay, so moderately then. So if I'm the treating physician, along with all this, I would need these 2-3 things more.
yes, sir.
Okay, so MRI is given to you. What will you do next?
So in Ganesh, in all probability, we'll say this could be parents 4 or 5, depending on what they have described.
हाँ सर, अभी बोल सकते हैं मतलब hypointense is supposed to be a malignant lesion on T2
Yes.
images. Now they don't have a DWI score here or a ADC put to format the pyrites probably.
Perfect.
Radiologist would correlate the enhancement as well as hypointense area, the hypointense lesion. They will see the enhancement, they will see the DWI in that, and then they'll see the value and then put some pyrites properly. So if we go with the doubt that this is a hypointense lesion where all these lesions are there, they will easily tell us which is more malignant or which is supposed to be the benign adenoid within that prostate. I mean, sometimes they even report in MRIs which also say that the bladder neck shows an infiltration or something. So they will have used all these parameters at that spot and given that answer to us.
True. So let's, for discussion's sake, take this as parents 4. So how will you proceed now further?
I will go ahead with the transrectal ultrasound guided biopsy of the prostate, a 12-core biopsy.
So given a choice, you had a transrectal, transperineal facilities available. What would you do biopsy? How many cores would you like to do? Where would be you said 12, that means you are intending towards a systematic biopsy of the prostate. So where all you need from?
Sir, what we usually do is in our institute, we go ahead with the transrectal biopsy. I don't have much experience with the transperineal. And that I would like to go with the ultrasound guided. And because we have a single lesion, according to the MRI, we can actually go with the cognitive fusion biopsy with the MRI and target the lesion mentioned in the right peripheral zone, along with the 12-core systematic biopsy.
Okay, so good. But shortcut my answers is literature does tell us that transperineal biopsies are coming into vogue because of less infection, probably less mortality or morbidity risk associated with it right now. why we don't do it in our country is a debate actually, but why we don't do it is because many times the facilities are not available with us. A classic transperineal biopsy needs a stepper and a software which is a small kind of a fusion software. The cost of that goes to something like 1.5 crores. What we use in the freehand, many people do a freehand transperineal biopsies with their techniques published. So that is with some kind of an adapter where the needle or the core or the needle cover cannula once introduced. Yeah, once introduced, after that you go freehand on a ultrasound probe and take 12 biopsies as you said. Now the whole reason of doing this MRI before the biopsy is so that you know where to take biopsies today. Literature with respect to that is evolving a lot, and maybe 5 years hence we might not probably do a 12 core but do wherever we find index lesions and important lesions we'll do biopsy. So you made a sentence that maybe I will do a cognitive biopsy. It is not maybe. Every time today the biopsy doing, if the MRI is there, should see the MRI and do a cognitive biopsy.
Okay.
Actual MRI fusion biopsies are quite superior, expensive, available at 2 to 3 centers only.
Okay.
So just for discussion's sake, because we are discussing now transrectal and transperineal, how do these two biopsies compare? Means what are the pros and cons of perineal biopsy?
Sir, with perineal biopsy, we can clearly take the bits from the apex of the prostate, which is not possible with the transrectal biopsy. Chances of missing the apex with transrectal biopsy are more. And with transrectal biopsy, the infections are more, and with transperineal, the infections are less.
Requires more expertise. Transperineal will require more expertise than transrectal.
So one area which definitely has an advantage with transperineal is the anterior lobe. So
sir.
the
Yes,
apex and the anterior lobe.
Okay, sir.
And the only drawback of transperineal, one is that it may need anesthesia, and two is the risk of retention is higher in transperineal.
Okay, sir.
Ganesh, is that, or you would add anything more?
On paper, they don't mention anything more. But as we see sometimes, because of transrectal biopsies, although there is no disease, sometimes when I do radical prostates, the posterior plane is quite bad. I don't know why. It is because of those bleedings or hematomas formed, or it is because of some chemical inflammation when a radiologist or somebody is putting some drop of formalin and putting the biopsy needle again. But I had asked this question to one Dr. Hashim from UK and in a conference, and he said the same thing, that even with transperineal biopsies, sometimes the apical planes of the prostates are not so good.
You know, there are some countries where they have completely banned transrectal biopsies.
I think in UK it is a standard practice now to do transperineal biopsies.
Yeah, I think it is Norway was the first country to ban transrectal biopsy. But you should confirm this. I am not 100% sure. Because of the risk of death, they took a legislation and banned transrectal biopsy.
That's why I said in our country, one is we need resources, and second, we need learning for everybody to do transperineal biopsies. That's it.
But I think we have to move that way because probably that's a better way of doing biopsy.
So Dr. Harish, I think we have discussed this topic. You are putting in chats MRI before biopsies. Also, the guidelines do say today that it is quite standard to do pre-biopsy MRIs, even when we are having once negative biopsies and doing a rebiopsy for a again elevated PSA. MRI before biopsies is a standard now.
Ganesh bhai, one question just for the students here and here. Are we moving into an era where, you know, they will stop doing biopsies sometime later, you know, MRI will improve, or maybe the imaging will improve further? Are we heading there, or we will still continue to do biopsies?
I think it is Norway was the first country to ban transrectal biopsy. But you should confirm this. I am not 100% sure. Because of the risk of death, they took a legislation and banned transrectal biopsy.
I have discussed this topic. You are putting in chats MRI before biopsies. Also, the guidelines do say today that it is quite standard to do pre-biopsy MRIs, even when we are having once negative biopsies and doing a rebiopsy for a again elevated PSA. MRI before biopsies is a standard now.
So
It will take time, I think, but we will head there finally, because I think in history of renal cancer, we used to have that once upon a time, but we have moved on to imaging almost 100% in renal cancer
Correct, correct.
for a pre-histopathology diagnosis.
Ji, moving, the way MRI has really moved in a positive direction. So just for that discussion, because they may be asked
Hiren,
this question.
there is a recent report where they have done a combination of MRI and PSMA PET.
Yes, sir. Yes, sir. That is why I was
And
asking that paper that
yes,
when they are
but
combining all these
even that
results, that
article has been criticized in a way that there would be two major drawbacks of skipping biopsy. One is that
Ji.
you will definitely miss low-grade disease, which may
Yes,
not
sir.
be important. But
Yes.
then having a histopathological proof probably is important whenever the patient fails later on. Say, do not do a biopsy and take the patient for radiation. Then
Yeah.
you will completely miss any histopathological proof.
Yes, sir. Yeah.
So with
So
the
just for the
combination of
discussion,
MRI
I
and
was
PSMA PET, it is
because
possible
there's a lot
to
of talk
diagnose,
on this.
say, GG2 and above malignancies.
Yes, sir. There's a lot of talk on this, so therefore I brought this question up.
Data is like being analyzed, but it needs time to tell us whether it is right or wrong.
And I also feel that the biggest, bottleneck for this would be the expertise to read MRI properly. Means even in the best of centers, the discrepancy in the reporting of MRI is quite high.
Plus standardization of the machines, sir. We don't know whether they are using the same quality.
Perfect.
MRI machines.
So, but Hiren, a day will come finally with AI.
Yes, Ganesh bhai. That's what I
going
feel.
to-
That
We are
maybe in
going
the
to
future.
feed in data of PSMA, PSA, and lesion for a retrospective large cohort. It
Correct,
will
sir.
someday tell you something.
Yes, sir. मेरे को ऐसा लग रहा है we are heading there sometime.
A lot of problems are there. Problem about biopsy and active surveillance. Problem about biopsy, metastatic disease. Lots of problems will be there.
Yes.
Fine. Sachin,
Go ahead, please.
Yes, sir.
show the biopsy. Yes.
Biopsy, sir.
Yeah. Can you read?
Sir, right side, 8 cores were removed and 6 cores were removed left side. And biopsy shows prostatic SNR adenocarcinoma, modified Gleason's 4+3 7 with pattern 4 component in 70% perinuclear invasion present, sir. Grade group 3.
Fine. So now next, Miraj.
Yes. Yes, sir. We can go for a we can go for a PSMA scan after this.
Miraj, one suggestion to you, do not say we can go for. You see, you are the treating person and you need to advise what needs to be done next.
Yes, this has a PSA of more than 10, a Gleason of more than 6, and also this patient.
Sorry, we missed what you said.
This patient has got a Gleason of more than 6 and a PSA of more than 10. And also this is more than a T2A lesion. So I would like to go for a PSA for this, to look for lymph nodes and metastasis.
So which cases you would not do a metastatic workup?
Low risk localized disease according to the D-amico.
Okay, that is good. Somebody has kept it on the horn. So low risk you will not do. Good. So here the cause is what? One is the intermediate risk, another is a primary pattern 4. Primary Gleason pattern 4, you should always do a metastatic workup.
Sir, Hiren, 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 Hiren,
Yes, sir.
There is something written in this report. B specimen B occasional foci of atypical acinar proliferation. So, Miraj, since you answered this, suppose if the A specimen would have been benign prostatic hyperplasia, and the B report would have foci of atypical acinar proliferation, how should we have interpreted that?
Athena, this is, I don't understand the question, sir. A
So
So
there are two
conventional.
instead of
right
in
B.
biopsy A, instead of malignancy, if they would have said BPH.
The right lobe is benign and left lobe says atypical acinar proliferation. So how will you counsel me?
He will still require, he may go in because of his age. He may go in for a focal therapy or a radiation therapy, or he may still go for a radical prostatectomy if he is fit enough. But
Sai Krishna, what is your
Sir,
opinion?
sir, I want a typical small acinar proliferation means some atypical cells are there which are present adjacent to the normal glands. So I want to repeat the biopsy after 1 year, sir. In this case.
Okay. So approximately 35-40% of patients
Yes, sir. They have the risk of
Will
malignancy.
develop.
ASAP will develop CA in a 5-year period.
Okay, sir.
So repeat biopsy is considered usually at 3 to 4 months.
Okay, sir.
Had this been HGPIN instead of atypical acinar proliferation,
They have the 40% risk of development into the CA prostate, sir. So
if it was a single core showing SGPIN, then
sir, then
everything normal remaining. There were 18 cores, one core says HGPIN, that's it.
sir, only if it is high grade prostatic intraepithelial neoplasia, sir.
That's the full form.
Only
What
if,
is that?
sorry, sir.
I said that's the full form, but what does it mean? What does it actually mean?
Okay.
I mean, is it cancer? Is it pre-cancer? What is it?
It's
Cancer,
pre-cancerous, like
sir.
cancer in situ, carcinoma in situ, like patient for the prostate.
Right. Full form everybody knows. You have to tell these things in exam. So what would we do with HGPIN? Suppose if it is HGPIN, what would have happened?
Sir, only if greater than 3 cores are positive, then we have to go for the repeat biopsy. Otherwise, not needed.
The scenario which I said, single core positive, then probably
nothing. Probably nothing. Yes, sir.
Is there any role of 5-alpha reductase or anything in such patients? No, there is no role.
Sir, no, there is no role, sir.
Okay, so Mehraj had said we'll do a PSMA PET scan. What is it?
It was a car. I would have. If it was a carcinoma, we can go for focal therapy. If it was HGPIN, probably we can follow it up on a surveillance.
But we are not talking about HGPN now. That is done. If it was, your answer initially was wrong about ASAP. Atypical acinar proliferation. Okay.
Okay, sir.
Even in this patient, what will you do further?
This patient has got a conventional prostatic acinar adenocarcinoma, which is Gleason 7 and which falls in a moderate risk group, so intermediate risk group. So he can be offered a definitive therapy. Considering his age, he may be.
Your investigation over?
No, metastatic workup normal.
Normal, okay. It is normal. Okay, sorry.
नहीं पता नहीं मतलब बताया
No,
नहीं.
we don't know.
Oh,
Yes,
I thought, okay.
No, but what is the role of is there any role of this thing, PSA density and free and total
Yes.
PSA ratio?
PSA density is more than 0.15 and the free PSA is less than 25%, and the PHI is more than 35. Then it is more suggestive of a carcinoma.
So PSA density and free by total PSA is more commonly used in the PSA range of 4 to 10, sir. As this is more than 13, I think.
About 10, it has technically no relevance for the free total ratio, anything. Anything about PHI, but these are all means for early diagnosis of prostate cancer in a patient may have an elevated PSA.
PSA velocity and doubling time.
Is there any specific scenario for which you are asking these questions?
No, sometime in exams, the examiner may ask them all these different questions. So that is why I said when we are doing this, just students should know. When you are there, you can just tell them whether there is any importance, because nowadays, I don't think that PSA density has got any value.
No, sir. PSA density is important in some situations. I'm sure Ganesh will agree with me. Especially if suppose you are evaluating a patient and it turns out to be PIRADS 3, then that is the time you look at PSA density. And if it is high, then that's an indication for biopsy in that patient.
That is given in the guidelines, right?
Yes.
But I mean, early diagnosis, some of these indices are important. PSA velocity, PSA density, वगैरह. About 10, the ratio PSA free total ratio loses value. Then we have the PHI test, which is technically available in India. It costs, I think, 4,500, and it has, as she said, it has a percentile value of more than 39 or 40, something like that. It is not very specific yet. It has not achieved absolute significance as per the other test, which is the 4K score test. 4K score test with the pro PSAs, HK2, HK3.
In that,
For a diagnosis of prostate cancer, and it can tell us where to do the biopsies in elevated PSA in which patients. Also in patients diagnosed of prostate cancer with 4K score test, it has been, there are publications which say they can tell us about the prognosis of the patient with respect to further BCR or metastasis free survival. This course is not available in India. दूसरा diagnosis के लिए we have only MPMRI and PSMA PET scan.
PSMA PET scan done or not done?
Then sir, they put up the report.
Done. Oh, it's a localized report. No extra.
So 77-year-old with intermediate risk. Correct? Grade group 3.
Yes.
Carcinoma prostate with a comorbidity of hypertension, I think.
Diabetes. 5 years on OHA.
So, Tanmay, what will you do?
Colonoscopy.
Sir,
you be sitting in your clinic. There are 5 anxious relatives with the patient. So, how will you manage?
So firstly, I'd like to discuss with the family regarding the life expectancy that his family members, his parents, uncles, or elder siblings had, to decide to get an idea about what further life expectancy we can have for this patient.
So how much life expectancy you are looking for?
10 years from now, sir.
10 years from now. Okay.
And and I'll explain to them that it is a localized prostatic cancer, and it has an option of an ablative therapy, which might carry a high morbidity at this particular age, and also give them the option of radiation if they are anxious for the treatment of the cancer.
First choice is ablative, second choice is radiation.
Yes.
Okay.
And if they want to
This is with respect to life survival, which is less than 10 years.
less than more than 10 years.
Okay.
And if less than that, and if they do not want to do not consent for surgery at present, I would advise active surveillance.
But you didn't tell surgery anytime in your choice.
So
It
first,
is not a case for active surveillance 100%. You see,
because it's a
any
high risk
patient with Gleason's 4 is not a case for active surveillance, especially means there is a pattern 4 of 70%.
Absolutely.
Yes.
So active surveillance is absolutely out in this patient. Your choices are between radical prostate and between radiation.
Radiation.
So what would you want to choose and how would you take this call?
I would like to choose radical prostatectomy because there's a good Karnofsky score of 80 and patient has only, I think, diabetes as a comorbidity. I would like to evaluate his cardiac function and pulmonary function, and if he is fit for anesthesia and a procedure, I would prefer a radical prostatectomy in this patient because it's a well localized disease.
My question to you is whether I'm just a question because he has got a diabetes, he has got a obstructive, complaints. Will you like to do urodynamic before doing any surgery?
So
But before that, I want to know about the uroflowmetry.
Uroflowmetry, I would like to see before that.
Q max is 10 and Q average is 4.9. So body volume 172.
Ganesh, a simple question.
Yes, sir.
Is there any importance in such cases of urodynamic to find out whether post-operatively patient will have any, incontinence, more chances or something like that?
Cleanly we don't.
No, sir, I don't think.
But grossly, if some problem is there, then we can consider. Now, uroflowmetry per se will not help us anything. It just tells us that there are severe voiding problems. This 4.9 ml per second. But otherwise, as I said, I would do a comprehensive assessment of the MRI. I will look at that 62 grams, whatever volume of prostate has an obstructive lobe, or how is it? We will have to see if the diabetes was controlled for a long time in this patient, because that itself can damage the bladder. We will have to see the actual life expectancy. Today, everybody is in a longevity. So if the life expectancy in this family he's 77 already, no?
Yes.
Yeah.
So his life expectancy 10 more years is like reaching 87. But we need a fit patient for a surgery. Probably there is a bias with that. Factors surgery. A lot of disturbance there. Factors going for surgery would be a probably better fit patient, patient interested in surgery, patient who has a lot of obstructive symptoms, patient who is probably one more thing I would say is at the older age group after radical prostatectomy, there is a chance of higher percentage of incontinence or urine leak rather, which is versus the younger cohort of patients undergoing radical prostatectomy. So that needs to be explained to the patient. For 10 years per se, the outcomes of surgery and radiation are, my cancer outcomes are going to be the same. What is going to differ is a functional or a side effect related profile, which needs to be explained in detail to the patient, and then he needs to make a choice out of it.
Fine. So in this case, Miraj, what you will offer him? You have to offer him. Patient is telling that, doctor, You decide what is right for me.
So his lower urinary tract symptoms seem to be quite severe with that 4.9 ml per second.
Yeah.
But then
He
you can
might-
also do a channel TURP, let the wound heal, give a hormone therapy, and give radiation after 3 months. No problem.
We can.
So Miraj, you tell us, na? You will not be wrong. Just tell us what you will like to offer.
He can, if he is fit enough for surgery, he can be offered a radical prostatectomy. And if he is, otherwise he can go in for a radiation therapy, which can be MRT or an brachytherapy. And yes, sir.
But before that, you will solve his lower urinary tract obstructive symptoms, correct? Either
Yes,
with
sir.
medicine or with surgery.
Yes, sir. So you are
No, as Dr. Ganesh said very rightly, no, you can give him hormonal therapy, wait for some time, right? And if he improves, then you can go ahead with the radiation therapy. If he doesn't improve, then you can offer him TURP and then go for a radiation therapy. But what is your choice? If you have to do,
I will offer him hormonal therapy and some
other two,
Sir, I'll offer him hormonal therapy and then see how he responds to it.
Response to what?
And I'll plan the next treatment depending upon how he responds to that. How he responds to the hormonal therapy.
Okay.
LUTS symptom improvement.
मुझे ये साइड का आंसर समझा नहीं मतलब.
Sir, after giving the hormonal therapy, I'll assess decrease in size of the gland by doing the DRE, and I'll assess the serum PSA whether it is coming down, and I'll assess the testosterone levels whether they are coming down or not, and then so that means there is response to the hormonal therapy. If there is a decrease in size of the gland, I'll plan for the radiotherapy, sir.
Okay. Matlab, with giving hormone therapy, what do you expect out of all three things you said? I think all will be responses positive only. I mean, I didn't understand. Testosterone, if you're actually giving hormone therapy, testosterone, maybe size will reduce a little bit depending on what hormone you are using. If you are using Degarelix, it is going to be faster. If you are using agonist, then it is going to be slightly slower.
What Ganesh sir is trying to say is, don't you expect a response? All the three answers which you gave.
Hormone therapy से वो response आने वाला ही है.
आने वाला है ना. So why aren't you saying that symptoms assess करोगे? You're not talking about symptoms. Symptomatically, you will assess the patient. No?
Yes, sir. Yes,
You
sir.
said you will see these three responses and add radiation therapy. Suppose if I hypothetically put it to you that the testosterone has not come to castrate range, it has reached 120, but not 100 after 1 month. What will you do? I don't know. So if you're going to take a decision on radiation, justify the decision right in the beginning, like it is not a wrong decision to give radiation therapy to a prostate cancer patient. I already said how we try to select a patient in the whole thing. But you will have to say why you are choosing a particular treatment. You might have to explain to the examiner.
Yes, sir.
that is why I'm asking you which treatment you will give and why. Only one treatment. You can't say I can give this also and I will give this also.
Whatever
You
Sai
say.
Krishna said, I'll see these three responses and then think of radiation is probably a wrong answer. according to.
Also, one of you have said radiation, so everybody is saying radiation.
If we have more cases, we should move on probably, I think.
Yeah.
And
Okay.
Okay.
if-
27-year-old, if he's extremely fit patient with LUTS, which is bothering him, or a patient who is fit and he wants surgery, we should offer him surgery after counseling him about the side effect profile. The other treatment which I would definitely offer to the patient is radiation therapy. Hormone in intermediate risk will be 6 months. The third treatment which can be offered in a 77-year-old patient is just watchful waiting. Watchful waiting is different than active surveillance. Watchful waiting then does not consider doing a PSA every 3 months or 4 months or 6 months. You have to tell the patient, okay, what was that on the screen? Okay. You have to tell the patient that watchful waiting means you are not on any treatment, you are not on active monitoring. Whenever you have complaints, you come back. This is not usually put as treatment, but watchful waiting means that.
Yes.
When patient has symptoms, he has to come back, and whatever is the stage at that time, a discussion has to be done about whether treatment is to happen or not happen. But there are a couple of people in life who will come and say, okay, I don't want any treatment.
Okay.
Last
So,
treatment which can be offered for a 77-year-old who may be, in a different state of ECOG vagere is sometimes not recommended, but intermittent androgen therapy.
Yes, sir.
Which is not in guidelines, but practically it is offerable. Intermittent because of the side effects, cost, vagere, everything. It will make the cells probably non-refractory, keep them not refractory, and we can have waxing waning of the cancer if the patient ages a little bit.
Yes, sir.
so
Okay.
in exam, in this session occur in front of you two things that LUT which needs some treatment. 1, 2. Is this patient is fit for surgery or not, and patient is willing for surgery or not? Question number 2. If the question number 2 is yes, this is a good case for radical prostatic pelvic lymph node dissection. If anyhow you are suspecting the life survival is less than 10 years, okay, patient is not willing for surgery, patient had lot of comorbidities, then you have to defend that and go for the second option in intermediate unfavorable risk, that is EBRT plus ADT. 6 months. Okay, if you are expecting the life survival is less than 10 years, then what sir told is few people say, I don't want any treatment. So such patients can be periodically observed. So surgery, radiotherapy, observation, 3 options. Tell one option in front of examiner with your own defense.
Fine. So we also did the radical robotic assisted radical prostatectomy on him, because otherwise he was absolutely fit and patient was insane, means he knew everything and he has come from Dubai only for the surgery.
No.
So considering all these things, we went ahead with the surgery. Okay, Achin, next case.
Sir, one doubt, sir.
Yeah.
Sir, can watchful waiting can be done in Gleason's 4+3 also?
Watchful waiting is a
Watchful waiting can be done in
kind
other
of an
states.
answer. It is not a which you will give. A patient in your discussion list will have that. So you don't have to tell him that watchful waiting is your treatment. You have to offer him treatments in a order of preference, which is going to be the last one.
Oh, okay.
Fine.
Sir, second scenario, sir. 61-year-old gentleman presented with complaints of urgency, frequency, hematuria associated with right flank pain on and off, sir.
So Ganesh, here we will not go too much in history.
So directly जाते diagnosis पे.
हाँ.
Distal rectal examination grade 3 prostate enlargement form nodular.
एक समरी स्लाइड है क्या अपने पास इसका? एज इतना 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 इतना, सो शॉर्ट केस ऐसा हो जाएगा.
Yeah, like this only. This much is the thing.
This much is the case, sir. And
ये
urine
स्लाइड पे एज कितना है?
61,
60 months.
So he had this thing, urgency, frequency, hematuria, and he had a pain in the right flank off and on.
And IPSS is 9, sir.
Yeah.
And digital examination, it's firm prostate, sir, grade 3.
Okay.
Move forward.
Urine routine micro shows RBC is 20 to 30, WBC is 10, more than 10, sir. Bacteria absent.
सर ये एक चीज मुझे बताओ, मतलब ये हर एक डीआरई में फीकल स्टेनिंग प्रेजेंट लिखा है एंड ब्लड स्टेनिंग एब्सेंट. सो इन यूरोलॉजी व्हाट इज द सिग्निफिकेंस? मतलब कैम्बेल में जो डीआरई लिखा है उसमें भी ऐसा कुछ लिखा नहीं है. Fecal staining is always going to be present if you are putting a finger in the rectum.
To rule out loaded rectum, sir, if it could be a cause of blood clotting.
What is the point in, I don't know, मतलब बाकी 4 एग्जामिनर है.
नहीं नहीं देखो
I don't understand the point in DRE and fecal staining. क्या फर्क पड़ता है?
Fecal staining doesn't have any clinical significance.
If examiners are asking this, then it is quite critical.
हाँ, तो उसमें कुछ लिखना नहीं लिखना तो
for piles or something, but we are not treating piles in urology.
No, bladder bowel dysfunction someone has written, that is a different entity. We are discussing here CA prostate. Bladder bowel dysfunction may caused by isolatedly by the loaded rectum once in a while. Okay, but loaded rectum is a indirect representation of bladder bowel dysfunction. So this is totally different thing. Here, writing a digital rectal examination and fecal stain, it is fecal stain only, no need to write.
No, I've never done a DRE and not got a fecal stain.
No, that is true. So that's what I am also going to. मैं भी वही बताने का कोशिश कर रहा हूँ कि लिखने का कुछ मतलब नहीं.
मतलब नहीं. मतलब if you have a loaded rectum, you write in addition. There is a loaded feces, whatever, hard stool, whatever.
Fine. So next time onward, Achin, please.
No, I don't know.
No, you are right. Unnecessarily, it will, the examiner will lead you to the different direction.
Chapter में DRE लिखा है. पढ़ लो.
Fine.
Okay. So, Tanmay, based on this history and this fecal stain DRE, what is your clinical impression?
It's a grade 3 nodular prostate, but firm in consistency. Though, so still my clinical impression will be enlargement of prostate.
Just go back one slide.
It's mentioned firm, sir.
Okay, 61 firm.
See, this patient has got LUTs, he has got hematuria, he has got pain in the left flank, na?
Right. Yes.
Right flank. And DRE, it is a firm enlarged prostate. Nodular prostate. Yeah.
So with hematuria and right flank pain, why are you keeping CA prostate as a diagnosis?
Just the presence of nodules. So otherwise, I would also like to consider differential of maybe a CA bladder infiltrating the prostate and maybe that presenting as a nodule. And also because flank pain possibility of a UTUC, but that won't explain the nodules in that case. But maybe a separate entity.
Clinically, LUTS and right flank pain goes towards some non-malignant diagnosis like
tuberculosis, GUTV can be another possibilities, and stone
disease, basically stone disease. But yes, right flank pain may be possible in CA prostate also. Wet it when it involves the right ureteric from inside or outside. So outside by compression of the nodes and inside by infiltration. And if there is a hydronephrosis, and that will cause a pain. But primarily, as sir said, CA prostate may not be the diagnosis with these two complaints, having a firm prostate.
Sure, बढ़िया.
Fine. So his PSA is now 8.74. What else now? What investigation you like to do?
I'd like to do a USG of the abdominal pelvis after routine blood investigations.
So tell us all the investigations you like to do.
Firstly, I'd like to check the urine routine and CBC and creatinine renal function test of the patient, and do an ultrasound of the abdomen and pelvis, focusing on the kidney, ureter, and bladder and prostate.
Achin, show them.
Sir, USG we don't have. We have CT because patient was evaluated for stone, sir. And the patient had right flank pain, but he was diagnosed with left renal calculus.
So now, next what you'll do? He has got a left renal calculus and PSA is raised. Miraj.
Ultrasound with a post-void residue and because yes, sir, to screen the prostate and the bladder.
I'd also like to rule out in presence of infection.
देखो, there are two things. One is a stone, another is urine routine shows some cells or WBCs.
Yes.
So the another is infection. And third is where, as we are discussing, the malignancy.
Yes.
So these are the three things. So we have to think by on three ways. Like malignant or stone disease, what is the status of stone disease? Then इसको serum creatinine करके CT IUP करना है तो CT IUP करा दो. यूरिन इन्फेक्शन है तो यूरिन कल्चर करा दो. एट ए टाइम मल्टी चैनल थिंकिंग करेंगे तो तुम इससे आगे बढ़ेंगे, ये तो वही रुक जाएंगे. और PSA ग्रे जोन में है तो उसका फिर तुमको फ्री PSA, टोटल PSA रेशो वो भी कराना है तो वो भी करा दो. ये तीनों चीज एक साथ बोल दिए तो एग्जामिनर को भी लगेगा कि यू आर थिंकिंग विद ऑल डायरेक्ट.
So now tell us what are the investigation you'll do and how you'll go about. How will you manage this case?
Sir, firstly, I'd like to do a urine culture and rule out infection. Secondly, I'd like to do a contrast CT and look for presence of any other lesion because it's a case of hematuria that has to be evaluated. And thirdly, I'd like to do a free PSA as well to.
So CT scan is in front of you, na? CT is already there.
Oh, that's a CT, sorry. That does not show any lesion on the right side to cause right flank pain, though it shows a staghorn calculus in the left kidney with patches of hypodensity in the mid pole of the left kidney.
Yeah, so that is a cyst.
Cyst.
So now, you want to stay here only with the stone only, or you want to do further?
Because the PSA is mildly elevated, I'd either like to do a free PSA or MPMR in that case.
Achin, क्या किया था? Just show them.
सर फ्री PSA किया था, फिर ट्रस वो 0.14 था, फिर ट्रस बायोप्सी किया था, उसमें मैलिग्नेंसी है.
So sometimes when you have an 8.74 firm and if your nodules which you mentioned on DRE are not hard, we would probably look at that urine routine microscopy and in the routine practice repeat a PSA value.
Yes.
True, sir. Exactly.
Don't forget that. I mean, in exam also you can say these things because these happen very truly practically and this has been discussed all over the world.
Okay.
Correct.
If you are going to directly do a biopsy, that's a different protocol altogether. Because the firm nodule, उसमें भी discrepancy है. But firm, if you say, then just directly biopsy में जाने की कोई जरूरत नहीं है.
Yes.
So actually, Ganesh, what had happened that since 2 years patient had a stone, he was, just because he didn't have any other problem, they said that you don't require any treatment for this stone. You just, when it will give trouble, we will do it. So that was number one. Number two, PSA was rising. So it was 5, then it became 6, 7, and by the time he came, it was, I think, 9 point something. So it was gradually increasing. So that is a time we intervened and did all the investigation. So when we investigated him, he had adenocarcinoma of the prostate, and he had come with both the things, all these things. He had come with the biopsy, he come with
Right.
the PSMA PET scan and CT scan.
Okay, no problem, sir. Sir, but for the students, like if it is
So
8
no,
point,
I want you how to go about in such patients
better is
when
to
they have
report
got,
the
for
PSA
example,
value.
sonography has shown there is a stone and PSA is high.
That is also one of the reasons for PSA to be high.
Yeah. But in this case, because PSA was rising, so that is why this.
Sir, what Ganesh sir is telling, and we routinely also, as examiner, accept that fact that this patient had multiple pustules in the urine routine. So we will go for culture and start culture specific antibiotic for week or two and repeat PSA free total and percentile at that time. And as per that report, we will go ahead. That is the routinely follow protocol majority places. So considering the rising PSA and having a nodule, firm nodule, so one can go ahead with MRA. That is another
MPMRA.
protocol, as sir is also telling.
Total PSA. At least for the exam.
Yes, 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 sir.
Right.
So if urine routine doesn't show any pustules, patients clinically doesn't have any symptoms of UTI, then what sir has telling that can be primarily tell. But with these pustules and PSA less than 10, it may be due to stone disease, it may be due to. So these are the things. So initially antibiotic therapy and rechecking of is a accepted protocol all over.
Yeah, I agree. So that is what it was done. Patient had already, that's what I'm saying. He is under treatment since last 2 years. So already multiple time antibiotics are given. PSA has been repeated. Continuously it is rising.
Right, sir.
Okay, so
Okay,
then
sir.
okay.
So this is a biopsy report or a PSMA report?
Both. It is written, na? Gleason score 3. Kitna tha?
3 plus 3 6.
3 plus 3.
Because if it is 3 plus 3, 6, then ideally we should like to know the number of cores, percentage of each core and everything.
Yeah. Unfortunately, what has happened that the
He's
whole
61-year-old must be sexually active person. So if he fits in the criteria of active surveillance, the treatment would be active surveillance.
True.
okay.
I mean, if this report comes to me, I'll try my best to search the report, do a review of that. And if not, at least see the MPMRI, looking at the index lesion, if absolutely necessary and patient is interested with counseling, I would repeat a biopsy and see what is the course percentage, course positive, and whether he fits into a low risk criteria for active surveillance. 40%.
The PSA less than 10 and Gleason's 6, I think he suits for active surveillance.
So our country, it is still accepted with a pinch of salt because many people don't counsel the patient for active surveillance. Otherwise, in the Western countries, 3 plus 3 is 6 disease, even with more than 2 cores. Now the percentage of active surveillance advised is more than 40%.
Okay. So
the 61-year-old, it is one of the best things probably.
It is come under very low risk or low risk criteria.
Okay. We don't have the, actually we have got the full report. Unfortunately, Achin doesn't have, it is lying with Dr. Paras, the whole thing. He has just taken it from the history.
Yeah. So PSMA PET CT technically is okay only, right? Peripheral zone, it says a single lesion there.
Yeah. So in this case, we should go ahead with the PCNL.
Okay, for the stone.
For the stone. So only PCNL. and then active surveillance.
So Sai Krishna, what is active surveillance and how do you generally do it? Since the incept of active surveillance probably today it is quite different.
Sir, active surveillance is carefully watching the patient for the progression of the disease with serial monitoring, and it will be followed for the very low risk and low risk prostate localized prostate CS.
And what is the follow-up done?
What is done?
That is more
Sir,
interesting because you told us the same thing which we told you for the last 10 minutes.
Sir, I'll follow up the patient with DRE, PSA, and if any progression of the disease is there, then I'll repeat the.
Sir, Sai Krishna, are you going to do 1 hourly DRE or what, 10-month DRE?
Sir, PSA and DRE every 6 months, sir. And
so it is a delayed primary treatment. Scientifically,
yes, sir.
Primary treatment, biochemical or pathological cancer progression. Correct. So how will you monitor? So you have to tell PSA 6 monthly, annually biopsy, DRE. समझो तुमको जितने बार कर 3 महीने जब भी पेशेंट फॉलो अप आता तो DRE करे, लेकिन 6 monthly PSA एनुअल बायोप्सी करना. हिस्टोलॉजिकल प्रोग्रेशन आ गया, बायोकेमिकल प्रोग्रेशन आ गया, उसको डिलेड प्राइमरी ट्रीटमेंट देना है. प्राइमरी जो फर्स्ट टाइम तुम प्लान कर रहे थे.
So the basic thing what sir is saying is the prognosis of this patient does not change just because he is put on active surveillance. He is in careful active monitoring, active surveillance, where there is a switch to an active mode of treatment in the treatment arm, whether it will be surgery or radiation, whatever. But there will be an active switch where the outcome will be as good by the delay. The delay will tell us, or rather give the patient a good time to live without any side effect profile of either kind of therapy. So this is the, whatever everybody is posting on the chat is the set protocol. I think it started from Toronto. And nowadays the protocol has been actually refining with whatever percentage I said of active surveillance. So many centers are nowadays doing DRE PSA at 6 months. And whenever they find any change in PSA, there is a thought of doing an MP-MRI. So whenever there is a change in MP-MRI compared to the baseline MP-MRI or the subsequent MRIs done, there is a need for a biopsy. So probably in future, this annual biopsy is going to go to whenever needed biopsy. It has already come in some publications, but not come in the guidelines as such. So it will come shortly. So they have pulled on the biopsy to a little more than a year nowadays.
And only contraindicated for African Americans and BRCA1 mutation carriers.
So another question is, are we able to refine how to put patients on active surveillance by any means?
There's the Epstein criteria, sir.
What is the Epstein criteria, man?
That is a decent grade group of 3 or less, T1C disease. And
criteria is the normal criteria which was put earlier to select patient for active surveillance. My question was, how will we refine our own decisions to put patients on active surveillance? So your Epstein criteria is there in place. I select 4 patients for active surveillance. But is there anything more what I can do for these 4 and I can tell them, okay, you are the right candidate, you are still the wrong candidate?
Any test which can predict which patient is likely to progress?
The prognostic markers and the velocity, like
PSA velocity, PSA density, sir.
No.
PSA indices don't work so good. Prognostic marker, Miraj, anything more on that?
Anything which you can do on the
काम नहीं होगा, कुछ और बोलना है तो बोलो. एग्जामिनर को ऐसा चॉकलेट मत फेंको.
PSA velocity, sir.
So it's important to read for all of you. you should know about genomic testing.
Yes.
Yes.
I just mentioned a little time back in my some test that 4K score, if available but not available in India, can predict some of the things. Similarly, there is a decipher test which can be done. It adds GPS score, genomic prostatic score, to your existing classification, and a paper has been published in 2017 or 18 in I don't know which JCO or something, where they have taken NCCN criterias, very low, and then they have applied genomic prostatic score with decipher, and they have further refined who's actually low risk. And these patients apparently will do best on active surveillance. Similarly, we have two more tests, Oncotype DX and Prolaris.
Prolaris, yes.
Also based on gene panels, they give a score and they will give you what score is safe for active surveillance. So this is important. Okay.
Okay.
I can see right now. So we discussed quite a lot on active surveillance, but I don't know. और गौरांग सर आप कुछ अलग क्वेश्चन पूछो जरा.
नहीं, the question is that in all the patients in such cases you are going to, suppose he has got a multiple course, it may be 3+3, but he has got multiple course, then what?
Sir, it depends. मतलब our low risk criteria में 3 course तक you can still offer. Literature now coming up says कि 3+3 you can generally offer. It has not come into guidelines per se. But today we follow that more than 3 course we should probably go on active treatment, which again will be surgery versus radiation, patient selection criteria along, patient choice, fitness, obstructive symptoms, same thing. But with a younger, if I have to answer for 61-year-old, I will probably tell it's a surgical treatment because he has a long life of 25 years probably, or 20 years for him. If I give him radiation, there is a good 10 to 15% chance of having a recurrence in the prostate, local recurrence, which is unnecessary. So I would offer him surgery at 61. Again, side effects of surgery is important, and there actually comes the place of active surveillance.
Correct. So if Achin doesn't have, but he had more than 3 courses, I think they were positive, and he was very, and continuously rising. He was very keen on surgery.
Right. So 61-year-old, sir, even if it was today high risk prostate cancer, I would offer surgery.
Right. So in this case, first we did PCNL, because after doing this, there are chances that he may develop some infection in the kidney. So question is whether you'll do PCNL first or whether you'll do radical prostatectomy first.
Yes, Miraj, answer that.
PCNL first, sir, as he has been placed on active surveillance.
No, it's not placed on active surveillance. Patient, I am the patient. My decision is I want surgery for the prostate also. Now you tell.
Then we will. It is showing a Gleason score of 6. But
Your answer is not descriptive. Your answer is I am the patient. I want surgery for prostate cancer. I know I have a stag horn. So what are you going to tell?
I will offer a radical prostatectomy.
You will offer radical prostatectomy first. Very good. Tanvi, what is your chance? What is your answer?
I'll prefer to do PCNL first, sir, because there'll be more chances of post-op infection with a stone there in C2. Secondly, per urethral access post uretrovesical anastomosis, I'll be more careful to go about that, sir.
6 to 8 weeks after a vesicular anastomosis, your urethra is going to be very good.
But Tanvi, the most important reason is that stone has a potential to damage, but this disease doesn't have a potential to damage immediately.
Damage, yes.
3+3, if you don't treat for 1 year, nothing is going to happen.
Nothing is going to happen.
Right?
Yes.
Nothing is going to happen. Miraj, you should remember that.
See, there are two things. One, this is a very important, that stone, even today, it may be silent. It is not causing much damage. But that doesn't mean that, for example, you do radical prostatectomy, you kept catheter for 8 to 10 days. There are very high chances of patient developing urinary tract infection, or maybe, it can go. And then this stone will get infected. So you have
Yes, sir.
lost the time. That is number one. And second thing, this is very important, that this CA prostate in few days, it is not going to spread. So best thing is to do. Third thing, I feel that sometimes it may be difficult. The approach may sometimes becomes little difficult because the ureteric orifice may come very near to the urethra, then cannulization and all these things might be. I don't know. I have never tried it.
So better to tell like it is low risk or very low risk disease, as CA prostate is indolent and this particular patient is in low risk category. I will treat her short.
Okay.
So in this case now, we did the PCNL first, and then we went ahead with the radical prostatectomy.
Okay. So we have report.
भाई कचिन रिपोर्ट है क्या?
इस पे तो नहीं है सर.
This is everything is with Paras.
Okay, no problem.
Anyway, so Ganesh, now today we are doing only localized CA prostate. So in that you want to add anything, because next time we'll be doing locally advanced.
Sir, add matlab nahi, but
Any other questions you want to ask them?
सर्जरी रिलेटेड पूछो सर, क्योंकि लोकल में आ जाएंगे.
नहीं मतलब उनको तो वैसे तो रेडिएशन रिलेटेड भी पता होना चाहिए, साइड इफेक्ट्स वगैरह जनरली. मतलब you choose between surgery and radiation.
So one of them can answer.
I think one should answer pro for surgery, another should answer pro for radiation.
Yes, that will be a great idea.
Yeah, you answer. What do you want to select?
First case, what we have discussed, that is in front of you. One will defend the radiotherapy, and another will defend the surgery.
So who is answering about the surgery?
Sir, I'll go with surgery.
Yeah, okay, tell us.
So firstly, that patient has presented with the complaints of FACULTIES, so surgery will be one-shot definitive way of treating that. Secondly, post radiation, if there's a rise in PSA, that and then salvage surgery again is not a good approach for that. And secondly, in surgery, we can tackle the localized lymph nodes and do a lymph node dissection as well. And giving radiation adjuvant to that, if lymph nodes are positive, will have a definite, will be definitely a better approach.
What is the most important reason for choosing surgery whenever you choose surgery?
The entire disease will be removed.
Yes, totally.
I couldn't understand. What is the most important reason?
The entire disease would be removed, is what he says.
Yes. And the long-term outlook of the patient beyond 8 years is much assured with surgery as compared to radiation.
Yes.
So rest everything becomes secondary. The most important thing is you get, you completely remove the disease, you get prognostication because you remove the lymph nodes. And then in most patients, you have cured the patient for life.
Yes, sir.
And who is talking against surgery? Sai, are you talking against surgery?
I think Miraj wants to talk in favor because she is not willing to do surgery. So she will like to talk about radiation. Miraj?
Yes, the radiation, if it is offered, then there is less chance of impotence and neurovascular nerve bundle injury. and there is less chance of incontinence and urinary related problems. And yes, sir. And radiation, if it is offered, this seeds will be placed, it is less morbid, and even if there is a lesser score for lesser cardiovascular compromise, then also he can be offered. And if he develops any kind of a recurrence on that, he can be offered adjuvant therapies like salvage lymphadenectomy or prostate. Again, radiation can also be offered to him, and he can be given ADT, androgen deprivation therapy, and yeah, he may be having some rectal problems which are more irritative symptoms. However, it has the same outcome, survival benefit for the patient. And yes.
You are answering very well, but just थोड़ा सा structure करो तुम्हारा answer मतलब. You are talking about radiation, so you should probably start with if given well and in the good protocols with the proper dose. The
It can
outcomes are quite similar till 10-12 years. That local recurrence rate remains actually with most studies which are published. And then you can say the other thing, you know, the side effect profile is different. There is in the initial, at least in the initial few years, there is no erectile dysfunction. There is usually no urinary, the leak complications are less. ED can happen after 3 years or 2.5 years post RT.
Yeah. So she has quite, nicely defended radiation therapy. But as Dr. Ganesh said, you should have proper 1, 2, 3, 4, 5 reasons. So can you just summarize nicely now and can tell us?
Radiation can avoid problem of an erectile dysfunction in the immediate few years. It may occur, if at all, after some 5 or 6 years. 20 to 70% chance is there, and it will avoid a problem of urinary incontinence and any sort of urinary incontinence. And radiation can be offered to people who have a compromised score of who have a cardiorespiratory compromise, who are not fit for anesthesia. IMRT can be intensity modulated. It can cover lymph nodes also, or brachytherapy can also be offered to them. And it has got the same survival benefit when compared to radical prostatectomy. And it can also be added if there is a recurrence, they can also go for more radiation, adjuvant radiation, or adjuvant surgery also, lymphadenectomies and salvage procedures, localized. And they can also go for ADTs. If there are initially high risk also, they can go for other procedures like ADTs and other things.
Fine. So
Can
you
you
have
quote some
defended
trials? Can you quote some trials comparing surgery with radiotherapy and the results?
Difficult है. Like it's like head-on prospective trials कुछ नहीं है.
Okay. Now one of them can defend surgery.
So, Tanmay, what are the problems you expect with radiation?
So firstly, we are not we won't be able to stage the disease completely. Like a histopathological staging won't be there. For a longer life expectancy, radiation therapy won't be as good. Secondly, we are not totally, there will be much better tumor control as we are entirely removing the disease in particular in this case of a localized, well-localized disease. Then also a salvage surgery after radiation will be difficult because of post-radiation changes in the tissues around.
Any radiation-induced side effects?
Radiation cystitis and radiation proctitis can be avoided.
I think you should have started with this and then gone to other things.
Yes. Yes.
So, Sai Krishna, can you tell us? You are being little silent.
Sir, with radiation therapy, we have the bladder toxicity, rectal toxicity, and lower urinary tract symptoms will be there, sir.
So you prefer surgery? So tell me the advantages of surgery.
Sir, advantages of surgery include the entire disease will be removed, and moreover, we have the exact assessment of the specimen, sir. And what is the margin status and exact stage of the disease and what is the margin status. And suppose if this patient, if radiation therapy is needed to be given, then we can give the radiation therapy. But when radiation therapy is given as a primary treatment, post-radiotherapy surgery will be very difficult, sir, because loss of fat plaques and fibrosis will be there. So that is a major disadvantage when compared to the surgery and the radiotherapy.
Okay. Ganesh, can you just modify them if you, in exam, how they should answer?
Sir, they should answer in the same way. I don't want to grossly modify. But when you are, say, going for surgery, as we started young patient, then good local control, gives good relief of LUTS. Then side effect profile, we all know the main two complications of surgery will be ED and urine leak. So you will need to quote these percentages. Long time control, we know, no need of, with the RAVE study data, whatever histopathology comes post-surgery, even if it is, say, it goes in, say, 25% of upgradation by chance, we would currently not add any therapy and subsequently do a 6-week PSA and every 3 weeks PSA and check on what further treatment if needed. So that is another thing with surgery. And then talking for surgery, you will probably criticize radiation, that although it is non-invasive, it still has a side effect profile. While having radiation, which can be either the usual fractions 36 or the hypofractionation schedule of maybe 25 or 24 fractions, you will still have acute side effects at the time of having radiation, which are related to edema within the prostate, increasing LUTS. There will be some kind of enteritis or bowel problems when you're taking radiation. And then the late side effects which might happen, which can be because of scatter radiation probably. You can still have a good prostate, but you will have a high frequency nocturia. You can have problems with passing motions. The frequency of motions increases in many patients. And they do report that the grade 3-4 complications in these two things are less, but commonly in practice we do see that. Again, long-term ED also comes as a side effect of radiation, because although the nerves are very near the prostate and they are included in the field, so they do get damaged. Now, this is about EBRT. You will need to read the guidelines for the brachy, which is in two forms, LDR and HDR. LDR is the one which Miraj said we implant seeds. So iridium Iridium seeds are there usually, which are implanted, usually used in low risk prostate cancer, usually. And brachy is optionally used in intermediate and high risk. High risk, some people don't recommend, but there are publications of using brachy along with EBRT in high risk. Sir, I don't know. मेरे को क्या बोलना था? मैंने ऐसे जनरल बोला.
No, I think it's a very informative, discussion that you've done it. So with this, I think at least in exam, whatever they say, whether surgery or radiotherapy, they will be able to defend themselves.
Yeah, so there will be one more scenario, like you might have an obstructed prostate and we want to push the patient for surgery. But if an examiner says this patient is totally unfit for a major surgery, then what will we do? Or something like today patient might be having an angioplasty just done and on blood thinners. Now what will you do?
Sir, I'll do the channel TRP and then keep the patient on watchful waiting.
Blood thinner पे ही है patient.
Okay.
Yeah, answer.
Sir, if
I'd like to catheterize, start TBRT with ADT in that case.
So again,
sir, I'll catheterize. Sir, can I?
the radiation given on catheterized patients has more problems somehow to the more side effects. This is what we had seen in Tata Memorial Hospital when I was there. So then later on they gave up the practice of catheterization actually. I mean, what I said is just a scenario for you. Patient commonly having angioplasty. So how do you manage technically? I have no answer specific to an oncologist like.
Can we give primary ADT, sir, in that case? See if the disease burden can reduce.
Yeah, I agree with that. You can give a hormone injection, wait for 3 more months maybe, and then check what happens to his LUTS. Maybe then do a channel TURP and give radiation, or at the end of 3-4 months, take up with a cardiologist. He has done angioplasty. The heart is repaired. Maybe you can go for a surgery later.
Okay.
Just because that angioplasty thing has come, we probably should not give up on surgery. It may be a 61-year-old patient on having an angioplasty. I don't know. There are 3 more examiners. Their views are.
No, I think you are right. Because with the angioplasty, once it is done to get a better life. And, so then we can go ahead with definite surgery also.
And if a patient is on blood thinners, then what is the view of people like, can you do a bipolar TURP on blood thinner if necessary?
Yeah. Even monopolar means, I don't know what the literature is saying, but we many times, if patient is on a low dose of ecospirin, we have done
generally stop, no, but sometimes we do get from the cardiologist that in this patient clopidogrel should not be stopped.
Laser, Pankaj sir.
No, I am just asking questions because we have actually done a TURP on clopidogrel also.
Is this is the right condition to use a laser?
The moment you asked this question, I immediately came back to screen and unmuted myself.
That's what.
Now answer kar do, please. These scenarios will come in life because of longevity. We are going to see all this more often.
Patients on antiplatelet agents, both say, especially on clopidogrel, TURP would not be the mode of treatment. This patient will need to be treated by one form of laser. Like if we just look at the risk of bleeding, probably green light laser would have the least risk of bleeding, but all 3 lasers are useful in patients where antiplatelet cannot be stopped.
I agree.
No, it is well-known fact that in such patients, that or with patient has got pacemaker, these are the cases, and large prostate. I think laser is the right answer. Barabar na?
Right, sir.
Fine. So we have discussed all these different scenarios. Next time we will go ahead with the locally advanced and then metastatic. So we'll have 3 different classes for that, and then we'll go for other malignancy.
Okay. So good night.
Okay.
Okay.
Okay, sir.
Happy Gudi Padwa to all and good night.
Good
Happy
night.
Gudi Padwa, sir.
And-
Good night.
Same to you, sir.
And please,
night.
Thank you, sir.
please attend our Saturday meeting. Is request to all of you. Okay. It is on 25th Saturday. We will put it on your group. Okay. Thank you. Good night.
Thank you, sir.
Good night, everyone.
अटेंड करने को
Thanks.
धीरे-धीरे गिफ्ट भेजना पड़ेगा
Pankaj,
सब.
thank you very much. Ganesh, thank you very much.
Sir.
Thank you, sir.
Yeah.